Good afternoon. I'm Michael Fehlings from the University of Toronto, and I'm pleased to participate in this course for the Cervical Spine Research Society. And this afternoon, I'm going to talk to you about different neuroprotective treatment options for cervical spinal cord injury, and we'll present to you the concept that steroids do represent a valid treatment option. These are my disclosures, none of which are particularly relevant to today's talk. So I'm going to talk about the reevaluation of corticosteroids, in particular methylprednisolone, and present this as a valid treatment option. I'll talk about current neuroprotective trials with particular focus on riluzole, and then I'll talk about some small molecule regenerative therapeutics, including anti-no-go, Rho inhibition, as well as some planned trials with an anti-RGMA antibody. So here are the learning objectives. I'm going to present the current AO spine guidelines for methylprednisolone acute spinal cord injury, and these do favor a role for methylprednisolone, especially for cervical spinal cord injury. And I'll list the key neuroprotective strategies currently under investigation for spinal cord injury. So traumatic spinal cord injury has a profound impact on the individual, and the deficits that arise will depend on the level of the spinal cord that's involved. But most injuries do involve the cervical spinal cord, which results in profound loss of motor and sensory function. Here's a case of a significant cervical spinal cord injury related to a subaxial cervical facet dislocation. And this commonly results in micro instability in the spinal cord, as well as ongoing compression and vascular changes, as illustrated in this animal model. This results in hemorrhage at the injury site with surrounding perivascular ischemia. And in this white matter region, there's ongoing neural cell degeneration. And then this culminates in the chronic pathology of a human spinal cord injury with cystic cavitation surrounding astrogliosis and anterograde and retrograde degeneration of white matter tracts. So the pathophysiology of spinal cord injury evolves from an acute injury to the intermediate and the chronic injury phases. And each of these phases has a unique pathophysiological features, which are potential therapeutic targets. So let's talk about corticosteroids, and specifically methylprednisolone. And because of the ongoing controversies related to methylprednisolone, we sought to issue new AO spine guidelines. And we did an updated meta-analysis of the literature, which was undertaken by an external group of methodologists to reduce bias. And the upshot of this are the forest plots as seen on this slide, and this shows a favorable effect of methylprednisolone in terms of motor function. Now, these are relatively small effects, but in patients with a cervical spinal cord injury, relatively small changes in motor function, for example, if you consider hand and upper extremity function, can have a profound impact on the patient. Importantly, there was no increased mortality with methylprednisolone, and in fact, there was a slight tendency to a reduction in mortality. And importantly, there's significant heterogeneity with regard to spinal cord injury. And let's talk about cervical spinal cord injury specifically. And in this patient population, corticosteroids actually had a 12.6% reduced risk of complications. So this was then filtered through the grade process where we take the best available evidence. We look at the clinical acceptability, we look at patient values, the costs and benefits versus harms. And based on this consideration, we would recommend that within 8 hours of injury, that a 24-hour infusion of high-dose methylprednisolone be offered as an option. We suggest not offering methylprednisolone as an option in patients who presented in a delayed fashion after 8 hours of acute spinal cord injury. And we also do not recommend the 48-hour infusion of high-dose methylprednisolone. And this is the infusion protocol where there are increased complications seen. So overall, there is no existing evidentiary basis to recommend against the use of methylprednisolone as an option, and the decision should be left to the discretion of the physician. But I would certainly strongly consider the use of methylprednisolone in cervical spinal cord injury and in incomplete injuries in combination with cervical decompression. So what else is on the horizon? So there are a number of neuroprotective trials, including the sodium glutamate antagonist riluzole that I'll talk about. There was a small trial with minocycline, which has now been stopped. And as well, there are early phase clinical trials with GCSF, which mobilizes mesenchymal stem cells. And this is ongoing in Japan. There have been some early efforts with neuroregenerative trials. There were some efforts with Sethren or VX210 through Vertex. And unfortunately, the recent randomized phase 2 trial was terminated because of lack of efficacy. There is an ongoing anti-no-go trial, which is being led by Armin Kurt in Europe. And there's a planned trial by AbbVie Pharmaceuticals looking at ABT 555, which is a monoclonal antibody directed against RGMA. This video will illustrate the concepts in the riluzole trial in acute spinal cord injury. We're studying patients with cervical spinal cord injury. Here modeled as a subaxial burst fracture. The primary injury is expanded to